And welcome again, everyone. My name is Blair. I'm the Marketing and Communications Manager for Prison Yoga Project. And we are honored here today to have two incredible leaders of the Humane Prison Hospice Project, Lisa Deal and Laura Musselman. I'm going to do a formal introduction of our guests, and then we're going to dive right in. Lisa Deal is a dedicated healthcare professional with over 30 years of experience in nursing, public health, and end-of-life care. After starting her career as a community health nurse for AIDS patients, she went on to earn her master's degree in public health and nursing and a doctorate in public health from Harvard University. Lisa has served in leadership roles at Mission Hospice and Home Care and is now the executive director of the Humane Prison Hospice Project, where she combines her expertise and compassion to provide dignified end-of-life care for incarcerated individuals. Everyone give that round of applause for Lisa, please. And we have Laura, incredible Laura, and her bio starts on a sad note, but I do believe she has shared that these experiences have really brought her to this path. After losing both of her parents, Laura transitioned from her role as a college philosophy instructor to pursue end-of-life care. She trained as an end-of-life doula with the International End-of-Life Doula Association and began volunteering at Hins Hospice in Fresno, California. Laura now serves with the Humane Prison Hospice Project, where she combines her background in ethics and her passion for accessible, compassionate end-of-life care to support incarcerated individuals. She also trains other volunteers, ensuring that those dying in prison receive the dignity and support that they deserve. Everyone, please give a warm welcome to Laura as well. Yeah. Thank you both for being here. I think what I would love to do today is start kind of big and then go into the details of our work. And I would love for you both to answer this question. What is hospice and why do you feel like it's important? And I'll send this to Lisa first.
Yeah, thank you, Blair, and thank you for the lovely introduction today. It's a pleasure to be here with everyone. What is hospice? Hospice is compassionate and dignified end of care in the last chapter of life. And hospice is both a philosophy of care that's been around for generations and generations. And now in the US, it is a Medicare benefit that people have a right to during the last 6 months of a terminal illness. It's been Medicare benefit in the US for about, since the 80s, mid 80s. One thing I want to do is people hear the words hospice and palliative care, and it can be very confusing. And we talk about them throughout our work because our work touches on both. So if you think of it as care is any care that focuses on quality of life and relief of symptoms wherever people are in their disease trajectory. So someone can be getting active treatment, chemo, radiation, and still have palliative care to really deal with their symptoms and their quality of life. They may have, chronic heart disease, lung disease, kind of any kind of illness, but it really deals with that kind of supportive psychosocial comfort phase of an illness and not the cure. And hospice is really just a subset of palliative care. And it is palliative care at the end of life. So typically during that last 6 months. And the 6 months is rather arbitrary and is really defined by the Medicare hospice benefit. And as anyone who works in end-of-life care knows, our prognostication, our ability to predict death is not great. So that may vary. And it's also very common for people to get into hospice care and actually do better because their symptoms are being relieved, their quality of life is being addressed, and so they improve. So it's an art and a science in both of them. So I'll stop there. There's much more I could say, but I'd love to hear Laura's perspective as well.
Yes, please, Laura.
Yeah, well, I think, Lisa, thank you for that definition. I, Blair, when you asked what's important about hospice, I think that there's so much hospice offers that is really essential to providing good care at someone's end of life. I think there are a lot of misconceptions about what hospice is. Certainly, working in community hospice, we, serve families all of the time who are really apprehensive about getting on service because there's this idea that if you get on hospice, that is the thing that is going to end your life, right? And that couldn't be further from the truth. People who are on hospice are already in the final chapter of their life journey. But joining a hospice service means that you are getting really comprehensive, individualized care to ensure that the quality of your life in your last couple of months of life, however long that may be, is compassionate and is really geared toward your preferences and interests and wants and needs. I think one of the best parts about hospice is the multidisciplinary team that serves each and every patient and their family or their loved ones, their community. You get a physician, a nurse, a social worker, a chaplain, a hospice volunteer, all of these people working together to ensure that your last several months are as comfortable and filled with as much life as they possibly can be.
That's so beautifully said. I feel so moved to tears by this work, and thank you for calling in the community of support of care workers that come and show up. And I think that's something that you've spoken about, Laura, creating communities of care within prisons. And it just it keeps rotating in my mind of that's what this work is we are creating and seeing these communities of care because they exist. Yes. How can we support them? How can we find them? How can we give them resources and training? And, I was looking up a little bit of these numbers, and please correct me. So the number of incarcerated individuals age 55 and older is growing significantly in prisons. And there's a few and many reasons for this. LWOP, or life without parole, started to really escalate, I'd say, within the last 30 years at least. So people are being incarcerated for life without a plan for them, without the resources, without the systemic infrastructure to care for people that are dying in prisons. So right now, it looks like there's about 186,000 people in prison right now that are 55 and older, which is 5 times more than 3 decades ago. They're estimating by 2030, 1/3 of all incarcerated individuals will be considered geriatric, placing immense strain on a system that is not equipped to meet these needs. So talk to us a little bit about how prison hospice got started, and then we can dive deeper into the work of what it is that you do and how you serve. Lisa, I'll pitch it to you first again.
Yeah, thank you. And thank you for sharing those statistics. Those are all right on and statistics that we use often in our work because they're so just astounding. So how did prisons hospice start? In the U.S., actually, we think the first prison hospice, many of these, as you said, Blair, are communities of care, and they form informally. There isn't a national registry of all the prison hospices in the States. But the most formal version of a prison hospice really started here in California at a prison in Vacaville, California, called California Medical Facility, where we actually do the training now, one of the places we do training in California. And it started back in the 80s when during the AIDS epidemic, which, as you alluded to earlier, was kind of my foundation into doing this type of work, also back in the 80s. And Elizabeth Kubler-Ross, who many people have heard of, sort of the mother of death and dying, realized that there were a lot of men dying at California Medical Facility of AIDS. And she just was really angered by the injustice of that. And so recruited a couple of friends and said, you need to go in and provide care and support to these men who are dying. And this is back, at the beginning of the AIDS epidemic where, we knew very little about AIDS. People did not want to touch AIDS patients. They did not want to be around them. And so kind of organically from there, this team of Elizabeth's friends and coworkers went in to support these men in San Quentin, and that was, at California Medical Facility, and that was really the birth of prison hospice in California, and we think in the nation. And from there, this again, so much of this work has been organic. Other prisons are dealing with the same issues, and they start creating these communities of care and support in their prisons as well. And it's really evolved from them. I think, and I say I think because this is always the number that we use, but I've read recently that it may be much higher, that there's about 1,800 prisons. And I think these are state prisons in the United States. Of those, fewer than 100, best estimates, and again, this data isn't out there firm and hard, or maybe about 70 or 80 have prison hospice programs. So there's still a ton of room for improvement. And we can talk later, or people have questions about how people die when there's not prison hospice. And far fewer than that have used this model of peer caregivers, which we believe deeply in and we can speak to too. It's really the center of our model of care. But I'll stop there because I'm getting off on a little bit of a tangent, but that's sort of, the origins of the work, and Laura can add more to that as well.
Yeah, I mean, I don't know how much I have to add. Blair, if you wanted to respond.
Yeah, I mean, Laura, maybe you can bring us into like the mission and the vision of the Humane Prison Hospice Project.
Yeah. So really our mission here at the Humane Prison Hospice Project is to revolutionize the way that people who are incarcerated experience their care at the end of their lives. If I had to sum up our long-term vision, it would be that we have a justice system that is less centered on punishment and control and violence, and really centers compassion and humanity. I won't pretend to sit here and expect that may even happen in any of our lifetimes. I don't think that negates the importance of trying. But, as Lisa mentioned earlier, hospice is a right. People have a right to good, compassionate end-of-life care. People have the right to have access to comprehensive health care that really centers their unique humanity. And that includes people who are experiencing incarceration. We aim to support those communities of care because they exist everywhere. That's another, I think, fairly common misconception that people have. I was actually just at a fundraiser last night speaking to somebody about the population that we see in many of our prisons. And it's less, these young, healthy people who are strong, and they more and more resemble sort of assisted living facilities. A lot of people in walkers and wheelchairs who are not able to access the healthcare that they need. And it's so especially important at the end of life because prisons are pretty traumatizing environments, to say the least. And we know that the end of life journey can bring up a lot of trauma as well. So really placing a focus on the most vulnerable people in that population and really empowering pre-existing communities of care to care for each other in the way that they know they deserve to be cared for.
Thank you. And you're touching on something I want to dive into deeper. So let's go there, Laura. Can you talk to us about how and why people age so rapidly in prison and how health declines quickly?
Yes. And Lisa, I think you can probably speak to this too if I miss anything. Most of our population that's experiencing incarceration are disproportionately Black and brown people who have come from backgrounds where access to healthcare was a problem prior to incarceration. It's a problem during incarceration. They are people who have been often overlooked for most of their lives in many, many different ways. So we're talking about a population that is in a place with very limited resources and cannot provide that adequate, at the very least, healthcare. But B, are coming into that system already not having received so much of it. So in a prison, you're not getting, I mean, talk about just the basics, right? Like having good sleep, a good night's sleep in a noisy environment where there's always something happening. You can never feel completely safe or secure. You're not getting really good nutrition. You're not having access to even just adequate, a lot of times, basic healthcare. The incarcerated population in this country ages approximately every 2 years to 1 year that we do who are not experiencing incarceration. Which is why that age 55 is typically the border for where we start to consider members of that population geriatric. Although I will say that I've been doing a lot of research on a few different projects lately, and I'm more and more seeing that age drop down to 50. So yeah, it's an especially vulnerable population, high rates of, mental health issues, sometimes substance use issues, and all really just beginning from a place where that access was denied from the start.
Mm-hmm.
Thank you.
Yeah, one thing I would add to that is, the access was denied, and these people, as Laura spoke to before they went into prison, were very marginalized. So there's a real lack of trust in the medical system. There was, many of these folks have had a lack of trust before going into the system, and certainly when they get into the prison system, because prisons are such a punitive environment, they really distrust the medical providers and may not even seek care to the extent that it is available, which is often very limited. And that's another area that our peer caregivers really help bridge, that we could speak more to as well.
So, and what I'm hearing when you say that is that people are waiting in prisons until there's almost a health emergency to request help. They maybe are likely going to be denied care. They are not trusting of care, or care is not even available.
Yeah. And I would say not even just, until waiting to request it. It's pretty well documented that healthcare providers also have a tendency to not trust patients. We see even out in the community that Black women in particular are frequently not believed by their healthcare providers. So we're talking about people who are going to their healthcare provider, asking for attention, asking for help, asking for them to listen. And there are many healthcare providers in this country, unfortunately, who say, yeah, I just kind of don't believe that the pain that you're feeling is real. I kind of don't feel like maybe you're not trying to just get some sort of painkiller for some other reason. There's so much distrust between healthcare providers and their patients, not just in prison, but you add the system to that and it amplifies exponentially. if you're a member of the incarcerated population and you're already having to live alongside correctional officers, custody officers, mental health providers who maybe are not very accessible. It's extremely hard to get an appointment. Healthcare providers who are so overwhelmed that they can't pay close attention to each individual patient. I mean, I would imagine there's not a lot of motivation there to even try sometimes. And then once you do try, to not be heard. It's extremely, it's devastating. And it's another form of trauma too.
Mm-hmm. Mm-hmm. Yeah. Yeah. Absolutely. And that trauma, sorry, I just want to add, that trauma extends not only to the incarcerated individuals, but also to the staff, because of the way our carceral system is and, these very antagonistic environments. Correctional officers have one of the lowest life expectancies of any profession because they too are consistently exposed to these punitive environments where there's this hierarchy and punishment oriented. So it is about the incarcerated individuals, but it's about and this gets to another version of the communities of care, the whole community, everyone that is affected by the justice system. It's really just not a healthy environment at all.
Thank you. And that's our shared vision, is shifting the carceral system from a punitive justice to a healing-based, compassionate system. I heard at some facilities in California, one mental health provider might have 200 clients that they're working with. Maybe they only see one person every few months. And we know that prison in America has also become the largest provider of mental health support or resources, right? That is what our prisons have become. So we have all of these overlapping issues. And now let's start to get into the healing salve. Let's start to get into the solution. So what do you feel like Humane Prison Hospice Project, what is the solution? I hear that it's creating these communities of care. What does that look like? What is the training? So let's dive into your ethos.
Yeah. Do you want me to start, Laura?
Yeah.
Okay. I mean, I think, it really is creating these communities of care. And we do this by really helping support palliative, end of life, geriatric, memory care in the prison system, and do this by trying to create multidisciplinary teams and communities within the prisons to care for those who are aging and dying. And the core of our work is really around training and supporting peer caregivers to provide the care for their incarcerated peers. And these peer caregivers, we can get more into our training. It's very in depth, but it really is to train these folks who are already in the system to be able to work as part of a multidisciplinary team alongside the nurses, the doctors, the chaplains, a very, very important role. I'm very sorry. I need to just turn off my phone. Sorry, I thought I did this before. The social workers, if they are in the prisons, to really be able to provide this care in that setting. And, the work that we do and part of the developing the communities is really, it's transformative. It serves a purpose both for those who are being cared for, but also for the peer caregivers who are learning these skills, who are able to give back in meaningful ways. Many of these people are, there for life, with or without parole. They will age and die in prison themselves. They have wronged society in some profound profound ways, but they want to give back. It's really a form of atonement for them. So it really benefits these peer caregivers who now have a sense of purpose, and it benefits the staff who witness these acts of compassion in these spaces where compassion is not common. And, then we see this ripple effect into the communities when, even just as we talk about our work, people have a different view of those in the carceral setting. They learn that these people are first and foremost just like the rest of us human beings. And although they may have wronged society in profound ways, they have goodness within them. And they often weren't shown ways to express this. So we give sort of voice to that. So there's this, cascading effect. And there are many ways to create communities of care. There are many organizations like yours who do this work in different ways. We all have to have a mission and a focus. And this is really our mission, but it's all part of this bigger circle that really slowly helps chip away at these settings that are very punitive and helps build them into more positive healing environments.
Thank you. And I know that we had spoken a little bit before, but I want to pull this in here now as well. There's compassionate release as well. And so I know that that's really not accessible for most people who are dying in prison. Laura, will you talk to us about what compassionate release is and how it will affect the work, or kind of what is the system of compassionate release?
Yeah, well, there's not really one straight answer to that because compassionate release policies vary state by state. 49 of 50 states have some kind of compassionate release policy. Iowa is, I believe, the only state without one. But the idea of compassionate release is that people who are in their end of life trajectory, who have a terminal illness or maybe just a really, really difficult chronic illness, who are of a certain age, can apply for compassionate release. And if that compassionate release is granted, they can be released and go home to their families and communities. I would say more often than not, the people who are applying for compassionate release and the few very fortunate ones who are granted it are no longer a public threat. I mean, we're talking about people who are often over the age of 55, who are deeply suffering in some way, and are just no longer a threat to society in any way, shape, or form. They've served long sentences, and when possible, they should be able to go home to the love and care of their families. Now, I will say that introduces one of the huge barriers that we often bump up against, which is that, at least in California, if somebody applies for compassionate release and it is granted, if they don't have a safe place back in their home community to return to where their medical needs can be met, they cannot then be released. And so we run into those sorts of barriers, really lack of housing and lack of access to the medical care that people need. There are a lot of people incarcerated in this country who have served such long sentences that they may no longer have any family left. They may be experiencing estrangement from their families. Their families may not have the resources required to care for them. That's true for many, many, many people. And unfortunately, because of the stigmas associated with incarceration in this country, many hospice, inpatient units, assisted living facilities, skilled nursing facilities do not have an interest in saving a bed for people granted compassionate release. And that's actually something that we are seeking to address some of the problems of.
Yeah, thank you for speaking to this so directly and deeply. as this barrier, and also reinforcing why it's so important to create these communities of care inside, because there are so many barriers. Yes, maybe someone would be able to be granted to be able to go and die with their family. But again, resources, availability, beds. So continuing to create these communities of care and hospice support inside, again, is just, I think it's just saying just how important it is when compassionate release just might not be accessible for most people.
Yeah. And I want to add to that too, that, you know, there are also people who do not prefer to be granted compassionate release. People who may have been serving 20, 30, 40, 50-year-long sentences, and they know no one in their community at this point. Their community is the people they've been living with for a very long time at that point. The people who share their lived experience and who, because they're in that position, can really provide the best care for them. You know, if I'm at the end of my life, I don't know that I want to spend my last days or weeks even further isolated than I already have been. I don't know that I want to go to a skilled nursing facility or an inpatient hospice home where maybe I have some awareness of the fact that they're kind of begrudgingly taking me in and caring for me. And also, I don't have my peers there who know me so well and know my needs and know my wants and can speak to them, who are my family at that point. So, you know, compassionate release is, in the best case scenario, a really great option. And also, it's not the one thing that's going to solve this issue, unfortunately. It's so layered, it's so complex. And this is really about meeting the needs of everybody, and everybody's needs vary so much.
Thank you. Really beautifully said. And let's talk about these peer support training that you do. I think this is really just the heart of the opportunity of the work of bringing hospice into prisons. Lisa, will you lead us in that conversation? What does your training look like, and what are the qualities that you look for when onboarding peer facilitator, peer support networks?
Thank you. Thank you for raising that. So the program we've developed over the last really couple of years, although we had a precursor program at San Quentin before that, but it was really developed in conjunction with a wonderful physician and her team who have led the hospice program at California Medical Facility that I spoke to for a very long time. And they had informally trained folks there for decades to be hospice caregivers, but it wasn't a formal program that was written down that could be replicated easily and scaled to other places. So we were invited to be part of this team and to really lead the creation of this curriculum. And we did so also, we did focus groups with men at the California Medical Facility who have been hospice caregivers to really learn sort of what resonates, what's important in their work. So the curriculum that we have now is, it's a Bible. It's a 550-page manual. It's 15 modules, 80 hours of training that these folks get. And it really covers kind of everything related to both hospice and palliative care, and also the soft side of this. So we train on the hands-on basic sort of basic nursing aid kinds of skills, how to move a patient, how to change a patient, all of those things. We touch on disease trajectories. And then the really core of our work that I think is most beautiful and most poignant and important is what I call the soft skills. And I don't like that term because it sounds like they're not as important. And I think they really are the core. But it is really about how to be a healing presence, how to sit with someone who is suffering, who is dying. We do a very long session on trauma-informed care because, as Laura has spoken to earlier, most of these folks who we are training to be caregivers have experienced profound trauma in their own life. They may have experienced death from, in their own families or a life that they've taken. And so learning to sit with death and dying brings up all these feelings. So we address that. We talk a lot about cultural competency. How do you deliver care to people that is really aligned to their beliefs and their values? How do you provide spiritual care for people who may be, religious or not religious, kind of have a wide range of their own walk in life. So they get this very, very in-depth training, and every module they do learning assessments. We used to call quizzes. We now call learning assessments, because they're really about how well we taught the material, how well it landed. They do writing assignments that our facilitators read, and they are, these profound reflections that these people express. And we really rely, our team goes in, Laura does a lot of the training, we're a very small team, does the training, but we also rely on community partners. We have a whole cadre of volunteer facilitators who are absolutely crucial to our work. And these are folks who are experts in the community. They may be nurses, social workers, chaplains, have, decades of experience in death and dying, all of these different areas, and they come in and facilitate different modules with the folks that we train. And we really share with our participants at the beginning of the training that we are not bringing this to them. We are all learners together. They have meaningful experiences. We have, maybe expertise in the area in the outside world. So how do you blend all this to really form these communities of care within the prison? So it's a very, very in-depth process, and it's really a very beautiful process as well.
I just hear so much integrity in the work that you offer. I know that you're currently in 4 facilities, going into a 5th, continuing to expand. And this is no small feat. You are coming in and creating a new system within a prison. And so I understand the need for a slow grow, right? That a facility needs to be stabilized and trained and supported, and then you can shift your energy to another facility and continue to grow and grow. I'm so curious to hear, what is some of the feedback that you're getting from these peer support people that are going through your training, and then they're sitting bedside with their community who of people that they love and that are dying? What is some of the feedback or stories and experiences that you're hearing from this community?
So Laura, why don't you take that one? Because you're actually in doing the training much more than I am.
Yeah. I've had the honor of working alongside a group of peer caregivers at the Central California Women's Facility for about 3.5 years now. And I've developed really strong relationships with each of them. And so being able to watch sort of growth of, just skills, knowledge, whatever over time is something I feel very privileged to be able to witness. I think the thing that comes up for me is the idea of purpose. I think as humans, we need purpose. And unfortunately, that's something we can't quantify when we're applying for grants or something like that. The impact that just having a purpose can have on somebody. I think anybody who works in end of life care understands what I mean by that, right? Like, you're sitting at a bedside with somebody. It's hard work. It's grueling. It's thankless. It's really, really deeply emotional, and also deeply meaningful at its core. So one of my favorite, I think, comments from a peer caregiver who we trained last fall there, she's been incarcerated for a long time. And after her first shift with her patients, I went in for a support session and just kind of wanted to catch up on how everybody was feeling. And she told us that, she'd spent a very long time waking up every morning late, not having anywhere to go, anything to do, any reason for getting up in the morning. And after her very first shift working with her patients, she told me she now skips to work. She gets up early. She skips over to the skilled nursing facility. She is a walker, by the way. But she skips over there, waits for her shift partner, and is just so re-energized in this chapter of her life. She's older. She spent a lot of time on death row when it existed there. And so to be able to begin this new chapter and have this new purpose and really deeply know that she's contributing to her community, you can't quantify. I mean, how do you even? It's one of those things that I think we hope all of our peer caregivers get out of doing the work. I think that's the goal. And it's also nothing that you can really sort of force. It's really about just the people who are doing this work are people who want to be doing this work. I've trained, hundreds of community hospice volunteers. I don't think anyone compares to the peer caregivers we work with at these sites. Each and every one of them are so dedicated and driven and compassionate and just creative and resilient and incredible. And I would hope that all of them would be at my bedside if I could be so lucky.
Mm-hmm.
Wow. Mm. With such a deep need, and I'm trying to hear the word, a rapid need as well, when we see the declining of health and the rising of age within prisons. What's the strategy to scale? How can our community support? What is the call to action for people that are doing this work, that are nurses, that are looking for a second career, that are social workers that are wanting to shift their impact or where they're wanting to serve? Like, what is the larger call to action? How can people get involved?
Laura, why don't I speak a little bit to the scaling, and then I'd love for you to speak to the call to action. So I think in terms of scaling, we have worked to this point primarily in California, but this is a problem nationwide. And as we do, as we speak, podcasts, presentations nationally, locally, write articles, people are hearing about this work, and departments of corrections, this is a huge problem for them. These people are aging in the prison system, and nobody really knows how to take care of them. And so we are getting folks from many other states reaching out to us and say, how can we bring this program to our state? So, we're in conversation with, I would say, folks from Department of Corrections or key stakeholders in a handful of states, 3 states in particular that we're really in the process of building something meaningful. 1 in the Midwest and 2 on the West Coast. And so part of our work now is, how do we scale this? How do we use this model, which we know has worked in California? We have this amazing training curriculum, and scale it to other states. And in doing so, and in the states we're beginning to work in now, we're looking really at, we're a very small team. There's 5 of us, that are doing this work, along with, as I mentioned earlier, this absolutely critical growing cadre of facilitators. But we're really realizing as we go into other states that we don't want to, go in and do all the work and leave. We want to build support, leverage capacity, leverage talent, create ownership in the communities where these prisons are. So we're really looking, as we go into other states, both to shore up our own training. We're developing a whole kind of toolkit and of implementation for how this can be done in other states, but also developing community partnerships with doula organizations, with nonprofit hospices, with, different partners in other states who can who can begin to own this work and do this work. So our vision is really to be able to go in and help set up these programs, help do initial training, train community partners, and then let them carry this forward in their own states. They know their state. Every state, political culture is different. The situations are different in every state, although many of the problems are the same. So we're learning as we go. We're developing as we go. How do we do that? And then our hope long term is that we can be a center for technical assistance, for sharing best practice, for bringing together people to share best practices so this work can really grow and grow. So, and Laura, I think that leads into some of the call to action and how others can get involved. So why don't you speak to that?
Yeah, I'll preface by saying that it's not easy to get into a prison to do the work. This is unfortunately not something where you can just go knock on the door and say, "Hey, I'd really like to help improve things around here." As much as we all want to do that, right? I mean, you learn about an issue that is so devastating and important, and you want to do something actionable. But it's a slow process. Working in this system, trying to navigate it is at times infuriating. It's unpredictable. Things can either happen all of a sudden or very, 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 very slowly. So all that to say, there's also not one, I think, solution. There's not going to be one, magic fix that solves this issue. We need people in their home communities to help us with advocacy, to help us with community education. I can't tell you how many times, Lisa or myself or another team member of ours goes to a conference, gives a presentation where somebody, at least 3 people in the audience say, "Oh my God, I've never even thought about this before." And of course not. I mean, there are so many things in this world right now that we are focused on that are difficult, that are heartbreaking problems. But the encouraging thing is that when people do learn about this particular issue, they want to do something. And that person may be the person who has a connection in the Department of Corrections. They may have a connection to the healthcare provider of that state's correctional system. You just never know. And so in terms of getting involved, I would say, if something speaks to you, do it. If you're a policy advocacy person, try to get a sense of the lay of the land for compassionate release policies in your state and maybe do some work on how that could be possibly streamlined. We're always happy to help and have conversations and support in any way we can. If you're an end-of-life doula, a chaplain, a social worker, a physician, a nurse, as we expand, we're going to need larger pools of these amazing volunteer facilitators to help us be able to do this work. If you work with a hospice organization or at a hospital or at a university, or you run a death cafe, we're always happy to do a presentation for your community to provide some resources and really talk about the issue. I really believe that small gestures of care and compassion can create large and lasting change, but it's not going to happen overnight. And it is going to require collective action from all of us together.
Every time you speak, I just thank you. It's these perfect segments, and I want to highlight it all. we really agree with the ethos of that. One, it's going to take all of us, and two, it's going to be a long process. So, I started to invite our community into the chat. So at this time, if you have questions or want to engage further, jump into the Q&A. But while our community enters, how do we keep going? What is the resilience or the energy? How do we keep our cup full, right? Because it is a long road that we don't know if these issues are going to be solved even within our lifetime. So maybe you can both kind of personally share what supports you and keeps you energized, or keeps you trying to stay out of burnout. What are the pieces of your life that you call in to continue to energize for this long road? Lisa, I'll give it to you.
Yeah, it's a good question. I do a lot of the, sort of the strategy work in the organization, kind of the executive director kind of stuff. So I'm not in the prison as much as many of my team are. But every training we do, I always try to go in 3 times. I go in and do part of the initial training. I go in midway, and I go in and I'm able to speak and be with the folks at their graduation. And it's such an important part of the work, because it's so incredibly inspiring. As Laura said earlier, any of these people, I would love for them to be at my bedside when I was dying. And they've done, these folks, many of them have had decades in prison, and they have done hard personal work that most people in the outside community have not done. And their stories, what they share just inspires me to no end. My husband, who works in business, he's an economist, and he loves to tell people, that I'm the only person he knows who loves going into prison. I get so excited. I get so energized when I come home, and it just, it gives purpose to my life, and just being able to witness this and be a part of this. And I think it really just continues to inspire me. And I think also just the traction that we've gotten, the fact that it's small steps, but we are beginning to see change, and we are beginning to make a difference in small places. And I just, am determined to keep this going as long and as far as we can. And, as Laura spoke to, and you spoke to bring others, this is about the community. It is about changing hearts and minds in the community. And the number of people, as Laura said, that haven't thought about this. I'm with friends, and I talk about this work, and I see people's minds shifting about, oh my gosh, maybe people in prison aren't as I see on TV. Maybe there is really a difference. And just to be a small part of that change is just incredibly inspiring.
Thank you.
Yeah. I was actually thinking about this last night. The first time I ever went into the Central California Women's Facility, it was the first time I'd ever been inside of a prison, and I had no idea what to expect. And before I left that day, I remember one of the caregivers asked me if I was going to come back. And I don't like making commitments unless I know like I'm going to be able to follow through, but I kind of knee-jerk said yes, and then just kind of hoped that was the truth. Because I didn't know. I hadn't processed any of it yet. But I did. And I've been trying to think about like what it was exactly that day that made me keep going back and I think over 3.5 years, I've maybe missed like 2 monthly support sessions with them. And it's just, I talked earlier about how incredibly, God, just dedicated and incredible they are. And I see how hard they work, and I see their resilience just in the face of so many systemic atrocities. It makes me work harder. I don't want to let them down. I a part of why I think I got into end of life care was because, Blair, as you mentioned, like I lost both of my parents and I'm an only child. And so the isolation of that was very, very real to me. And then I work with these incredible people who should be home in their communities, giving this care to their families and their loved ones. And I don't want them to feel alone. I want them to feel supported. I want them to know that people care about them. And so I keep showing up, and the showing up energizes me. I mean, there have been days I've gone there where I've gotten very little sleep the night before, or I'm getting over an illness, something like that. And it's like, as soon as I get there, I'm awake. I'm awake and I'm high energy and I'm just so excited to see them. But the burnout's real too, right? And there's a definite spectrum to this work where there are days that I have to get up from my desk and pace around in a rage. The wins sometimes feel few and far between, but they're big wins. And when they happen, it feels like a miracle. So, yeah.
Thank you both. Thank you. And Lisa, I would love to, maybe it's part 2 of this. You have just had so much experience and training and wisdom and knowledge in nursing and end of life care and 30 years of experience. So I just want to maybe kind of bookmark that for another time and dive into your 500-page training and like all the things that you created. It's just really, really incredible. And at this time, we'll start to shift to questions from our community. First one that we have here is, does the Humane Project engage only with incarcerated individuals, or is there a family involvement in the process?
Yeah, that's a good question. We do primarily engage with the individuals. The peer caregivers themselves engage with the families. Often they are the ones in the prisons, and not every prison is set up this way. The families can come and visit and be involved, and they're a critical role there. So I would say that we support them in doing that, in being able to engage with other families. And I'd also say that that's kind of, something that we look to on the horizon. We have done presentations at national conferences of family members of incarcerated people, and look to ways that we can do that more in the future. But primarily our work has been, with the folks. Laura, do you have a different perspective or thoughts on that?
Yeah, I mean, we don't typically get to engage with the families. That's mostly the work of the caregivers, and the multidisciplinary team. I have had a few opportunities to be able to engage with the families of patients, though, and those have all been really incredible experiences. We were actually able to have a memorial service at the women's prison for a patient that the team had cared for probably 8 or 9 months, and her daughter came, and it was just the most beautiful thing. I mean, it was just all of us sitting in that chapel, her daughter sharing stories of who her mother was prior to her incarceration, and all of this woman's friends sharing stories with this woman's daughter about funny things that had happened over the last couple of years. And just to really be able to see the impact of, like, this woman's daughter understood very deeply that even though she couldn't be the person caring for her mother was being cared for by people who really, really understood her and loved her. And that was, I think, really healing for her. And just to have an opportunity too, where she could, talk to the peer caregivers themselves and thank them, because, you don't often get thanked in this kind of work, and you especially don't in a prison. So being able to have a family member come and look them in the eye and say, thank you, I know that you did incredible work and I'm so grateful, was really valuable.
Thank you. my puppy just woke up, if you hear a little bit of barking in the back. But as we continue with our questions, the prison community is near and dear to my heart. How can one become involved or volunteer with little to no formal experience in this line of work? I do have personal experience with family members who have passed and cared for them in their last days. So what would you say to people that do feel really called to do this work or are already doing volunteer work in prison? How can they get involved with this project?
Well, I would say it's little to no formal training. I would encourage some continued education, maybe do a training to be an end-of-life doula, start volunteering with a local hospice. Because the way that I first started doing this support in prison was actually through a nonprofit hospice that had developed a relationship with the team of peer caregivers like 20 years prior. It was a pre-existing relationship. And I just happened to be working at the hospice and found out about this and sort of jumped in and started helping. So I think, maybe gathering a little bit more training and information is a really good place to start. I think also if you have a particular skill set that maybe could be utilized at a local prison in a different program as a volunteer, that would be useful too, because then you can get your foot in the door there and start to get to know all the people who actually make the decisions that impact the community. So those are two really good entry points, I would say. Lisa, if you have anything to add.
No, I think those are great. And in terms of doing that, the actual work in the prisons and beyond that, I would say thank you for being here today, for learning and spread the word. Start being part of that shifting the narrative and shifting the messaging around the importance of this work, what is happening, and just how people in prison are human beings, and they are capable of doing really meaningful and wonderful things if they're given the opportunity.
Thank you. This ties in perfectly with our next question. How do you actually get a program to be allowed in each prison, and what is the role or who is the first point of contact at a prison?
Yeah, I would say it varies. It varies depending. I mean, in California, we're working very closely with the physician I mentioned earlier, who kind of invited us into creating this work. And she is head of the Department of Corrections not head, but she's an executive within the Department of Corrections to really develop and expand palliative care, geriatric memory, palliative hospice care in the prisons. So having her as an advocate here and having her pave the way and starting to identify prisons and helping get prisons ready to accept this work makes our entry generally in California relatively easy. I say relatively because not all prisons are as excited, even though she's leading the charge to do this. But wardens in prisons are very important. Chaplains in prisons are very important. If any prisons are doing, elements of this work, finding that spokesperson within the prison who is really shepherding this along, connecting with departments of corrections, getting, in the states that we're working in now, we're working directly with folks that are high level within the departments of correction and finding who those people are and getting their ear. As I said earlier, these issues are issues that prison systems are dealing with and know are going to grow in the future. But that's part of really part of our work too, and building local capacities. We go into other states is because every state may look a little different, and you need champions in that state who are going to take the time. And as Laura said, the wins are sometimes, it take a long time between them, but really there's a lot of legwork that goes into finding who those right people are. So it's very variable.
Yeah. I would say typically, and again, I can't emphasize enough how much this varies from place to place because every state is different, every Department of Corrections is different, and every individual site within that Department of Corrections is different. And so it requires a lot of research, a lot of talking to people, trying to figure out who the right person is. Typically, at least in California, this is true. The community resource manager is the person at the prison who oversees all of the programming and also all of the gate clearances. So let's say you wanted to begin by volunteering for a program already in existence at the prison, just to kind of get to know people and make yourself familiar. The community resource manager would be the person you would want to get to know, because they would be the person to approve your volunteer packet and let you in, and you can't really do anything without them. So if you're looking for a more specific role, I would say start there.
Thank you. And as we are starting to end our time here together, I would love to give you both just the mic back for anything that hasn't been touched on, anything that hasn't been discussed today, or anything that you want to leave our community with. Laura, we'll start with you, and then Lisa will end with you.
Yeah, I'm going to use my little bit of ending mic time for just one more shameless plug for how to get involved, which is you can always donate. We are a very, very, very small nonprofit organization. We run completely on a lot of individual donations and grants. And so if facilitating is not something that is possible for you at the moment, or if you just really want to be able to do something to contribute in some way, please know that your donations, no matter what size, they directly impact our participants. They pay for the printing of the manuals. They pay for our gas to get there. There's basically no overhead involved here. So, they are really, really, really meaningful. And I'll just leave it there.
Thank you, Laura. Yes, that's always an awkward thing to have to ask for, but that's how we run and are able to do this work. But I don't really think I have any. I think we touched on. I mean, there's so much more nuanced, to talk about, but I think we covered everything. I would just like to end with saying a tremendous thank you to everyone in the audience and everyone who will listen to this when it goes out, up on your podcast. And just you are already a part of this work. Just being here. This is not an easy topic, talking about death and dying, and particularly death and dying in prisons is not an easy topic. And one of our co-founders always used to say that, prisons are as much about keeping people in as keeping the community out. And we live in a society that we like to put people in prison and, kind of put them away and not really think about them. But, everyone on this webinar today has just demonstrated that they want to engage. You're either doing work, in the prison already, or interested, or, involved in end of life work, I imagine. And like you're making that first step to just expose yourself to this and to be open heart, have an open heart and an open mind to how we can continue to build these communities of support in some of the most difficult, challenging places. So thank you for being here. And I would welcome, you to reach out to us. There's ways to do that on the website. And, Laura is wonderful. It may take some time because she's very busy and doing a lot of things, but, does connect with folks who reach out, and we're always willing to have conversations. We also have information sessions once a month if you want to know more or ask more questions, that you can come and continue the conversation. So thank you, and thank you for this opportunity for us to be able to share today.
Yeah, and feel free to find us on social media too. I try to be more or less as good as I can be about posting reminders. Our October informational meeting is actually just around the corner on Wednesday, the 16th at 10 o'clock a.m. Pacific Standard Time. And just, one final reminder that even though this is an incredibly dehumanizing system, recognizing the humanity of the people it affects is one of those really important ways that we can begin to chip away at it and make it better.
This was absolutely incredible to be here today and to hear about your work and this momentum and energy moving forward. Thank you. This has been absolutely my favorite conversation I think that I have ever had. It is so important.
Oh.
So deeply. So thank you both for being here. Thank you for your continued and endless work. Again, we are here with the Humane Prison Hospice Project. I am going to put the donate link into the episode description as well. And we really encourage, I don't know if you guys have like monthly donors. I know that a small bit goes a long way. Maybe it's $5 a month. Maybe it's $10 a month. Maybe it's something that you can continually show up for over and over again. Think of your coffee going to supporting people in need in these prison systems. With training and support and end of life caring. Thank you again to our community and everyone who showed up. Thank you, Lisa. Thank you, Laura. And I can't wait to have you back and update everyone on this continued work. And thank you so much for being here. And we'll see you all next time.